So hi everyone, my name is Aneri Pattani. I'm a senior correspondent with KFF Health News. Welcome to this session, which is all about what's happening with all of that opioid settlement money. This is a topic that I've been covering for about 2 years now, so I'm really excited to discuss and share with you all and hopefully inspire all of you to report on this as well. So very quick background, I'm sure most of you already know this, the opioid epidemic has a long history in rural communities, many of which were targeted by pharmaceutical companies and flooded with prescription painkillers. Now, a lot of those companies are paying out tens of billions of dollars through legal settlements. And the money's supposed to provide this new opportunity to address the crisis and prevent things like this from happening again. But there are concerns about how much rural communities will get, who's in charge of that spending, and how much of it is going to evidence-based practices versus not. So today we're going to discuss these issues a little bit and how you can cover them with two experts who've been deeply involved with the opioid settlements in their own states. So we have Glenn Sterner, who's Associate Professor of Criminal Justice at Penn State University. And we have Chastity Toole, harm reductionist in rural Maine, as well as a member of the Maine Recovery Council, which is the council that makes decisions about half the opioid settlement funds in Maine. So thank you both for taking the time to join us. Before we start, I just want to put a quick reminder out there for everyone watching. If you have questions, be sure to put them into the Q&A space. You can see that at the bottom of your screen. It is different from the chat. So try to use the Q&A so that we can look for the questions there, and we'll kind of bring them in. I'll bring them in as I can. But we also have dedicated time for Q&A at the end. So if you put in the questions while we're speaking, that way it's on your mind, you type it out, it's in there. Even if we don't address it at that moment, we will go through all of those towards the end of the chat. So feel free to use that at any point. So to get us started, I kind of want to, before we hit the opioid settlements, let's talk more about just the substance use space and what that looks like. So we've heard a lot about the opioid crisis, starting with prescription painkillers, often targeted to white working class communities in rural areas. But the crisis has transformed quite a bit over the past few decades. And today, when we look at the data, the fastest growing rates of overdoses are among Black Americans and often in major cities. For both of you, Glenn and Chastity, I mean, you work with rural communities and you've been in the addiction space for a while. Can you each talk a little bit about how you've seen addiction and overdose trends change, particularly in rural areas of your states? Glenn, why don't we start with you and then we'll go to Chastity.
Yeah, happy to. And again, thanks again for inviting me, and really excited to be here, mostly because I think that this is a really important topic to report upon. So, Aneri, thanks for pulling this really great session together. So my name is Glenn Sterner, Associate Professor of Criminal Justice at Penn State. But really, I work with a whole host of colleagues across the entire country. And one of the things that I really hope that you gather from the work that we're going to be talking about today is that when we talk about rurality and we talk about rural spaces, we kind of lump them all together, that they're all the same, that it's either urban or rural. And what you probably know is that when you go to different cities across the entire country, or frankly the world, they each have their own unique culture, their unique opportunities associated with them. And rural spaces are exactly the same way. There are unique opportunities and unique spaces associated with our places that are deemed rural. And so as we think about the issues of the opioid crisis and we think about the issues of substance use, likely those are going to be unique to those locations as well. And so when we think about your locations that you're particularly interested in, whether it's your home place or it's places across the country, I really hope that you take a little bit of a deep dive into some of the realities associated with those locations, because what happens over here in Appalachian East Coast is very different than what's happening in the Great Plains, is very different than what's currently occurring over in the West Coast. And the reason that I talk about it in those ways is because we now know that those different use trends and those use patterns are shifting across the entire country. We see that Pennsylvania has traditionally been a place where we consider the heart of the opioid epidemic that has hit the country, along with West Virginia and along with Ohio. But that's not necessarily always the case anymore. We've seen increasing overdose death rates in rural spaces across the Great Plains, all the way to the what we consider the West Coast area. whereas there are an emerging set of needs and issues associated with what we consider Appalachia and the Mid-Atlantic states. And so in Pennsylvania, very specifically, what we've been really seeing is this emergence of what we consider uh, uh, emerging substances and substances that might not necessarily be on the tip of people's minds when we think about overdose as well as substance use patterns. And some of those are an infiltration and adulteration of the illicit market. So, for example, you likely have heard of fentanyl. You have probably heard about xylazine, but you're probably not thinking about things like nitazines. So there are new emerging substances that continue to infiltrate our supply. And this is for a whole host of reasons, both in terms of intentional use patterns. So individuals who are seeking, who are actively utilizing substances across our communities are perhaps seeking different ways to think about their use patterns, as well as hopefully finding ways to address issues of harm. And so they might be seeking utilizing in different substances for those reasons. And in Pennsylvania, what we've seen a drastic uptake is frankly, an increase in use of stimulants. So all the way from cocaine to what we would consider methamphetamine, as well as prescription stimulants. So those that we typically get from a doctor. And so one of those things that we really want to be at least aware of is that, again, even in Pennsylvania, those patterns are different across our state. So the western side, we typically see much more stimulant-related issues. We have now seen movement of the xylazine infiltration move from the eastern part of our state all the way to now the west. And so it is something that we're continuously monitoring, and we really want to make sure that we understand the unique needs of all of our country, excuse me, all of our rural spaces across our country as well as our Commonwealth.
Absolutely. And Chastity, I saw you nodding at several of those places, and I know you are, working with people who are using drugs pretty regularly. What are the changes you're seeing in your community in Maine?
Yeah, so for me, for people to understand where I am, I'm in Washington County, Maine, so as far east in the United States as you can go, and grew up on the Canadian border in Calais. Washington County was like talked about all the time in the early 2000s as one of the places that were targeted. And that's when my use started, was back then, when it was Oxycontin. And through the years, there's been so much that has changed. You know, each time there was a crackdown, criminalization, we'd go on to the next thing. And like the way we are with everything in life here is like we're behind the rest of the world. So before the new wave of substances hits, we generally know what's coming because we can see it move to us. And like for context on the rural nature of where we are, I built a syringe service program that served this whole county that I've been operating for the last 4 or 5 years. Our county, I got to look at my numbers. We have 31,000 people in 3,300 square miles. So lots of space, very few people. Another rural program in our state, it has, it was like 25,000 people in 30 square miles, and that's considered rural. So like really looking at how when we talk rural, there's so many different variations of what that actually is. Here, just over the last few years, what people use has changed at a much quicker rate than it had over the last 2 decades. Like it was all opiates, and now it's all polysubstance use. And on one side of our county, that means methamphetamines, but the other side of the county, it's crack cocaine. And then they just inexplicably like switch. And so it's really fascinating how you have to like be really engaged and connected to your community to actually know what's going on, because you can't keep up with it. And like just listening to the police reports is how like people try to keep up with it, and that's not a good way to do that. Like finding out what people use after they've died from it, that's not actually helping people.
And while we're on this topic, I see a question from Aaron in the Q&A, and I'm just going to throw it at you all now because why not? So he writes, Montana just started testing for, ooh, my pronunciation on this is going to be interesting. Benzimidazole slash nitazines. I know nitazines, so I don't know how to pronounce the first one. I'm curious whether how common these families of drugs are becoming. Either of you want to take a stab at that?
So one of the great not-for-profit organizations that is actually helping us to make sure that we're thinking about the active drug supply here in Pennsylvania. Chastity, I completely agree. When we only focus on toxicology reports or mortality reports, that's not helping us making sure that we're thinking about what we would consider emerging issues across the Commonwealth. I think of the Commonwealth, but across the country. And so one of the great organizations that we have is the Pennsylvania Groundhogs, and what they do is they test active users and specifically the drug supply of those who are actively using. And so when we think about making sure that we can keep people safe from a harm reduction perspective, this is one way to do so. And what they are seeing is that nitazines is starting to infiltrate the supply more than I think that we even expected. Particularly here in Pennsylvania, it's not in every county and it is not in every location. But what they are doing is they're making public their reports of their testing so that we can at least be aware of how that's spreading across. But frankly, we don't know. And the reason that we don't know is that we're not all actively testing for nitazines or even some emerging substances that are coming across that we're getting aware of from the Customs and Border Control perspective, because typically that's where we see a lot of these emerging substances initially start to pop up with regards to the way that we're testing and we're monitoring them. But we're also thinking about this from the national early warning system perspective as well. And so there's a whole host of folks who are starting to really pull together these data, but honestly, we have a long way to go.
All right, so I want to get us to the opioid settlements. So let's talk about the money part of it now. But like this is great to lay the groundwork of, the settlements are coming because of the prescription opioids and the marketing of them, but the issues we're dealing with today are different from what they were then. So the opioid settlements, the funds began arriving in bulk in late 2022, early 2023. There was a lot of variation there for different parts of the country. But they are flowing now, and states basically had to make decisions about how they would split up the money. And every state has done this slightly differently. And in terms of how much is controlled by a state, how much is controlled by local governments, and how they allocated, if it's going to local governments, how much does each city or county get? So, Glenn, I wanted to have you talk a little bit about how the settlement money was divided among counties in Pennsylvania, because there was a national recommendation, but you all chose to do something different. So can you tell people a little bit, just briefly, what the national recommendation was, and then why you chose to do something different in Pennsylvania?
Yeah, and happy to talk a little bit about both the process of the how it is we decided to break this up amongst our counties, but also the discussion around the control of the actual location of the funds. And so for us, what I'm going to talk about is the ways in which we decided to split up the allocation to the 67 counties in Pennsylvania. And so the national model and the way that we split all of the funds across, well, the way that we will now split across all the funds across all the states is really based on 4 different measures. And so the 4 different measures specifically, and they're weighted differently, by the way. First is overdose deaths. So that's the first measure. The second is amount of opioids dispensed. And this is through the automation of reports and consolidated order system, ARCOS. And the third is prevalence of pain reliever use disorder. And then finally, population estimates. And so those 4 were how they decided to break this up across the various states. And they weighted those according to the severity of how it is that they felt that this would potentially help to abate these needs and issues into the future. And I think that is really important to highlight here. So this was not, these settlements were not meant to make up for losses. These were not meant to make up for losses of lives, losses of expenditures. And there have been many reports that have talked about how much money has been spent on the opioid crisis. I've written about this myself, but there's no way that we could ever recoup those dollars. And there's no way to make up for the lost lives of individuals that we love and that will never be back with us. And so what we wanted to switch our perspective on is, so how do we help to abate this issue into the future? And that requires a lot of crystal balling, right? Like, so unfortunately, none of us are perfect when we start to make those predictions into the future. But what we can do is we can utilize science and we can utilize statistics in order to help to understand how we can utilize existing data to hopefully approximate some of these needs into the future. Well, for those of you who have ever worked with data or have ever tried to understand some of these data sets that help us to understand substance use issues, first of all, they're not always easy to work with, right? They're not, they are from multiple locations. There's no centralized way to get access to these data. So that's one of the really big problems that we came across when we were thinking about this, because when we were told that we needed to help to identify how it is that we were going to break these funds up in Pennsylvania, I think that we had the span of roughly a couple of months, 3 months or so, because frankly, the settlements, as you all are aware, when you deal with the legal system, it can be really unpredictable. And so it's unpredictable when it's settling, and it's also unpredictable when it sets its own deadlines. And so we had very little time in order to develop what this could look like for Pennsylvania. And we also had to get everybody else on board in Pennsylvania in order to then sign on to the settlement. Those are two different processes. I'm going to talk about the science. The other is for my colleagues who had to do all that arbitration. So when we took a look at some of these data, some of it, frankly, just wasn't available for every single county across the Commonwealth of Pennsylvania. So you can't get prescription pain reliever use disorder prevalence rates through the National Survey of Drug Use and Health, which is what they use at the national level, for every single county in the Commonwealth of Pennsylvania, because as we know, they tend to mask associated with particularly rural spaces with regards to some of the responses. And this is a survey, so it's not always representative all the way down to the county level, and certainly not down to anything that's less than the county level when we think about that for places that are rural. So we wanted to make sure that we were able to help to understand some of those issues of use, but we couldn't necessarily do so with the given data that we had. The other issue that we had was the issue of the population. What we found was when we were starting to run correlations amongst our models to help to predict, the population is completely connected to overdose death rates, the rates of other issues associated with substance use. And so by adding in population, it really didn't add anything. It didn't give us anything additional that we weren't already capturing with some of the other measures that we were picking up. And so what we did was, our initial proposal was that we would focus on overdose death rates, and we would focus on amounts of prescription opioid painkillers in MMEs dispensed by county, and we weighted them equally. And the reason we went for those two was, first of all, we had confidence that the data was accurate, and that we also had active access to these data in order to predict these. And we also had reasoning for understanding that these probably are going to help us to give a solid indicator of those places that are going to continue to be negatively impacted by the opioid crisis as it continues to emerge over time. But what we also, in that process of negotiation with our colleagues across the Commonwealth of Pennsylvania, is that we became aware of other data that could help us to approximate that perhaps even better, because of additional data that they had available to them that we weren't aware of. And so that included opioid use disorder related hospitalizations. So that gives us, again, maybe a little bit better of some of the issues associated with use earlier than overdose death, which is a better indication of use patterns. And then also EMS administered naloxone. So this is, again, naloxone is the life-saving medication to help to make sure that we can reverse opioids. And so we utilize some of those data to help us understand where perhaps overdoses were occurring, but maybe weren't being captured either by hospitalizations or by overdose deaths. And so by examining those data across all 67 of our counties, again, important to know that we can only, we wanted to make sure that the data that we had available also represented rural spaces as well. And we felt these 4 measures did so. And so that's how we weighted ours. And frankly, we also wanted to make sure that our rural locations received at least enough money to make a market impact. And so we set a floor of roughly $1 million from the beginning that every single rural location would get, so that as you, again, we talked about the connection between population and these other measures. Frankly, it just was so small if you didn't include that floor for some of these locations that it wouldn't even have, a small amount of money to actually do stuff with, even from now and into the future, because these payments are ballooned. You get more money in the beginning, and then over the course of the next 18 years, they taper off over time. And so that was our method for distributing these funds across all of the Commonwealth of Pennsylvania, including making sure that we had some equity for those that had the least population.
Yeah, and I just want to underscore for the reporters, I know sometimes we hear a lot of data, a lot of numbers, it feels wonky or distant, but like the measures matter because of the last point that Glenn just made. Because a lot of the data points that are being used to split up this money scale with population, rural areas, even if they were really hard hit, proportionately, might be getting very small amounts of settlement money. And so trying to figure out how to use that to then address their problem can be a real challenge. And I know from looking at different parts of the country, some places, right, are getting like $100 in a year. What do you do with that? And so that can be an interesting reporting question to ask, especially in your smaller communities. Like, are those places going to pool their funds together? Are they going to save them up over many years? Are they going to try to get a foundation to match whatever they got? Things like that. So Chastity, I want to ask you, you live and work in one of those rural counties. How has the way Maine has split up the money, kind of what's coming to Washington County, and how sizable is it to address the problems that you see?
So the way Maine set theirs up, 50% of the money goes to the Maine Recovery Council for us to get out, which that part is actually great because that's where all of the transparency requirements are, which is important when I get through the rest of this. 20% goes to the Maine Attorney General's office, and he can make the decision of where it goes. Since it's state government, there's still transparency requirements, but not on the same level that we have. And then the 30%, that goes to the municipalities that participated in the litigation, which is all of the counties, and then certain towns or cities. But in the rural areas, that's very minimal. Like Cumberland County is Maine's most populous county in the whole state. And they have...
That's where, sorry, that's where Portland is for folks.
That is where Portland, Maine is. So they have the money the county's getting, along with, I don't remember the number, so don't quote this part, but like a dozen towns that are also getting funds. So like they've been able to work together, pool their money, and then figure it out from there. Washington County, where I am, there's the county money, pretty minimal. And then one town, Calais, is the only one getting funds. And it like a pitiful amount that I don't know that it would even give someone a full-time salary to do work. So figuring out something that would have covered all of the counties in an equitable way would have been really, really lovely. And unfortunately, we didn't get to do that. So part of what the council has been working to do is trying to collaborate with each county. So maybe we can help support something they want to use their funds for. So it's not just the little bit that they get. And I think this might be in questions later, but I'm going to say it now. A lot of the counties, since they don't have a whole lot of guidance, don't know what to do, or I guess municipalities is better. They're just listening to law enforcement, and a lot of them, that's where their money's going, to stuff that law enforcement wants. And they haven't figured out an actual process for public comment and figuring out what your community actually needs. So there's a lot of work that could have been done differently, but I'm hopeful that at least the Recovery Council, we're able to model for the rest of the state. So as each year progresses, maybe we can pull the other counties in to be able to work more collaboratively and get some more transparency on their end, because they don't have the public reporting requirements for towns and counties. So we don't know what they're doing with their funds until reporters find out and put it out there for us.
Yeah, and I will say quickly that if folks are interested in sort of the transparency and reporting requirements, we can certainly get more into that with the Q&A. Feel free to drop a note. That is sort of an ongoing huge theme across the country, that like people care about this money. People died, and that's why we have it. And so people want to know how it's spent and where it's going, but depending on where you live, and what the requirements are, it can be really, really different being able to, how much you can find out about how it's being used or not used, or who makes those decisions. So that is the brief version, but happy to go more into it with the Q&A and have Chastity and Glenn weigh in as well if folks are curious. But because Chastity, you started talking about kind of, where it's going, where you want to see it going, I feel like you segued us perfectly from process into like actual spending. So let's talk about first, where do each of you think opioid settlement dollars, or how could they be invested to benefit rural communities most? Chastity, you'd already started a little bit, so I'll ask you to kick us off there, kind of what you want to see, and then we'll talk about what you're actually seeing.
Obviously, I would love to see more harm reduction investments across all rural areas. I mean, we're traditionally the places that don't have access to things. Like we have to drive an hour and a half for a Walmart. So like we don't have, I know your eyes said it all, that's life. But to traditionally not have access to the care that we need and we deserve. So being able to bring more harm reduction services across all rural areas, some mobile services across the board, MOUD, everything, and not putting it in jails or buying the cops their fancy true narcs, investing in drug checking programs, housing, basic needs. Like there are so many things we could do. And like this money is a lot and there's a lot of potential, but it is just a drop in the bucket for what our communities actually need and deserve. So that just feels really important to acknowledge and put out there. Like it's not going to solve all of our problems.
Absolutely. I think that point is, I've heard a lot, like this money is a huge opportunity and it can make a difference, but no one's thinking it's enough to solve the crisis. So in some ways, I've heard folks say that makes it all the more important to use well, because it can't take care of everything on its own, but you have to use every dime that you have effectively to try to make some amount of difference. So Glenn, I'm curious to ask you the same question, kind of what do you want to see this money go to that you think would make the most difference in rural communities? And then we'll talk about where it's actually going so far.
Yeah. And Chastity, I think you're exactly right. Thinking about the issues of access is really important here. And so one of the things that I started out this discussion with is that each rural community is quite different, right? And so what I would really like us to make sure that we remember is that these indicators of public health, of use, they are going to tell us what, frankly, we should be utilizing these for in order to address the issues that are unique to our communities. And so I'm not going to tell you that you should use that every single rural county should be utilizing these types of strategies. But what I really want us to make sure that we're thinking about is that the use of data and the use of evidence when we start to decide what those needs currently are. And so that requires us to, frankly, understand what indicators of public health and safety are telling us about our communities. If we know that youth use patterns are changing and they are changing drastically, perhaps we need to make sure that we're really thinking about the prevention programming that we're putting on for our youth within our K-12 system and frankly across our communities. If these are issues where we know that we are seeing high levels of overdose attached to xylazine, perhaps we need to make sure that we really invest in xylazine testing strips and make sure that we blanket the communities with those things, right? And so we can't know what those things should be unless we're doing an honest assessment of the existing issues within our communities. But one of the other things to recommend is that we think not just about the data and evidence, but allowing a little bit of flexibility so that we're not only utilizing evidence-based practice, because that is a really important aspect of all of this, and we want to make sure that we're having the highest likelihood of success. But you can also move into this realm of what we would consider research informed or evidence informed that doesn't have that very specific moniker. And I say that because that allows us to do a bit of, frankly, innovation, right? Like there's probably really cool programs out there that are helping to make sure that communities are getting access to whatever they need in specifically rural places that they haven't really thought about before. And so there's ways to make sure that we're testing those, making sure that we're documenting their impacts, and then hopefully spreading that in other locations across not just our states, but frankly across the entire country as well. And the other thing that I will say is that when we start to think about the use of these funds, we want to make sure that we are considering issues that really make sure that everyone has access, right? We typically think about rurality again as a panacea, but frankly, there are different individuals across our locations and across our communities that might have different needs, and particularly those that have English as their second language, we want to make sure that those communities are also having access to these types of things as well. So really taking a look at who makes up your county, who are affected by substance use related issues, and how is it that we can make sure that we continue to utilize these funds in ways that again will hopefully zipper with some of the other funds that are available to these locations.
Wonderful. So there are two questions that came in, and I want to shoot one to each of you. So Chastity, I think this one will be perfect for you. Aaron asks, how can harm reduction and treatment services be placed in a way that will boost access for rural communities? In Montana, these services are typically put in hub towns. Are mobile services the answer?
Yeah, so as I said at the beginning about building a certain service program in my county that I've operated the last few years, it has been mobile. I started during the beginning of the pandemic where our governor issued some executive orders that got rid of our awful antiquated one-for-one exchange rule and allowed for mail-based and home-based delivery. So being able to serve the community in innovative ways, being able to mail to folks what they need, or, like you deliver a pizza, go and deliver what people need. That has been the most effective model that we could have ever asked for here and around other parts of our state. As far as treatment, utilizing what we had to during the pandemic and more Zoom telehealth, that has been something that's allowed more access to people that traditionally have not had that. One downside of that in some rural areas is access to phones, but actual service or internet. So being able to provide options for that for the people who don't have their own, whether it's someone who can go to them or providing phones for their participants, their patients, providing phone cards, and just really talking to people for what they need. But I think the more personalized it can be to truly meet people where they at, the more success that we'll be able to see.
Awesome. Thank you. And then Glenn, I want you to address hopefully this other question, which kind of relates to, so the session right after us is a documentary screening about the impact of generational substance use disorder in one family. And so the question is, what do you think about opioid settlement funds being used, or is there an appropriate use for these funds in helping kids who are affected by the way substance use disorder affects families? So even if a child is not using substances themselves, how might these settlement funds help them affect them? How could they be used?
Is that session This American Family?
No, it's Inheritance. I don't know
Oh
if you've
yeah,
seen it, but
yeah, both of those are really great films. So So the answer, I think, is yes. So there are certainly ways that we need to help to make sure that particularly individuals who have been affected by substance use, even if it's not their own use, particularly children, I think it's important for a couple of different ways to be thinking about this. First is through primary universal prevention. So there are lots of really great programs, communities that care, a whole host of others that life skills training. There are lots of really evidence-informed and evidence-based prevention programs that can help them understand how do you break that generational cycle, particularly with regards to substance use related issues. So that's really important, and to provide them to think about this more than just one substance, but what are the skills that they need in order to help to address these issues on a more universal basis. So primary prevention, primary universal prevention, I think is perhaps the most important. The second is making sure that they're also looking out for co-occurring disorders. So we know that substance use and mental health disorders co-occur. Trauma, ACEs, adverse childhood experiences. Those are the types of things that we really need to be concerned about when someone who is perhaps living in an environment that is either unstable or can sometimes be just frantic. And so we want to make sure that we're helping to support the mental health needs of these children now and into the future, and helping them recognize and destigmatizing asking for help, right? Whether that's for them or for a loved one, we want to make sure that people recognize that reaching out for help is perhaps the strongest thing that you can do, because it lets other people know that you have the ability to show that you care for yourself as well as for those around you.
Thank you. So we've talked about like a lot of great ways the money could be used, things you both want to see. Let's talk about where the money is actually going so far. And again, we are relatively speaking early days. The settlements with different companies have different payout timelines, but some are going to continue paying annually through 2038. So there's a long time frame on these, but places are starting to spend the money, state governments, local governments, and there's a host of ways we're seeing it be spent. A lot of it is, treatment, naloxone, recovery facilities, but there are also some things that have come up as concerning in my conversations with both of you and lots of others. So I want to peel off sort of two concerning themes that have come up and have each of you speak to one of them. Chastity, you mentioned this a few times already, but there has been a lot of money that I've noticed, particularly in rural areas, but also in some urban ones, going to law enforcement. And this can range from buying new squad cars with the opioid settlement funds to the drug checking machines like TrueNarc that you mentioned, to starting addiction treatment programs in jail, which a lot of people actually think, there is a lot of evidence behind that and a lot of people actually support. So it's not to say, across the board, there's been criticisms, but a lot of money is flowing to law enforcement systems. Have you noticed this in your community? And can you talk about ways that it concerns you and ways that it might be helpful?
Yeah, so the municipality 30% part, that's where we've really seen that here. There's been good and bad to law enforcement. There's been money that is to cover Medicaid assisted treatment in jails, which that's good, but it's also something that they're already required to do and should be providing. But some of them, they want to only do the shot because it's less work for them, but the cost is exponentially higher. Like per shot was like $1,500 or something, and that's not sustainable. So there's good and there's bad. It's not being weighed out. There's been different stuff going to jails. I already lost my list. I had a whole list of stuff that cops were getting here. There's one part of our state where they're trying to get like $7 million in settlement funds to build this great big facility, which on one side it's like treatment housing, but the other side of it, it's a police training academy. And it's like, yes, there's a good part here, but that feels like a small added part just so it would be covered for what they're really trying to do here. So I think that we just really have to look at what are people actually using it for, like the bare bones, and what does your community need? On the council side of it, we haven't given any to law enforcement. And I'm actually really proud that the first money that we voted on and allocated was for syringe service programs. Like it was the first vote on any money. There was like no negotiating, no one was against it, unanimous. And that was a really proud moment because there has not been anything else that we've been on the council where we've all just agreed. And that was the one I thought I was going to have to fight really, really hard for. Some law enforcement stuff, it's been liaisons, so behavioral health liaisons. That part can be good, but it's not. I wish that we could really track and see what they're doing with all of it because we don't know what's good and what's bad. Like we shouldn't be paying for police cruisers or those machines. I hate them and I'll say it over and over. Like they're not truly effective, especially when that's just bringing criminalization into people's lives. Like if we are going to be supplying money for drug checking equipment, it should be community drug checking equipment. So I don't know that I answered because I started rambling at my hatred for True Narc.
No, thank you for talking about that theme. And this is just sort of the surface of that issue. And you all, this is a introductory panel. Everything we're touching on, there's so much more to get into with the story there. But sort of similarly, another concern that I've seen and heard a lot about is money going to treatment and recovery facilities, but some of these facilities don't allow the people there to use medications for opioid use disorder. These are things like buprenorphine and methadone. But that goes against best practices. So Glenn, I'm wondering if you can talk a little bit about if you've seen money to go to these sorts of facilities and what concerns that raises for you.
Yeah, and one of the things that I want to highlight for Pennsylvania very specifically, I didn't talk about this, is the control of our funds. So all of our funds are overseen by what's called the Pennsylvania Opioid Misuse, Addiction, and Abatement Trust, POMAT. It's a very long name, but I call it the trust. So the trust is who oversees it. But really, all they're doing is they are a bank account and they are making sure that they are monitoring compliance. And one of the things that they have really specifically done is not make any suggestions around the use of these funds. But they also have made sure that the funds in Pennsylvania are not going to solely law enforcement and very specifically enforcement of laws around substance use related issues. So that has been something that has been disallowed from the very beginning. And I'm really actually quite happy about that. And as somebody who's as a criminal justice professor, you would think that would be a little sad, but I fundamentally believe in evidence and really making sure that we're thinking thoroughly around the use of these funds. And that's why I'm really sad to say that I do know that there are treatment facilities that exist in Pennsylvania that do not believe in medications for opioid use disorder and medication-assisted treatment more broadly. And so I know that those funds are going to locations that disallow those things and might even segregate individuals who are using MOUD and not using MOUD. And sometimes they don't even allow those folks to be in the same places. And frankly, that's why I'm really excited to be able to talk to you a little bit more today as far as the audience goes, because you as reporters can help us to understand that this is something that is evidence-based. Utilizing a medication to treat a disease that is something that requires prolonged, sustained treatment is something that should be talked about as normal as diabetes or anything else that requires a medication. And so the way that we talk about MOUD and the way that we talk about medication-assisted treatment continues to have a very stigmatizing perspective. And that isn't just for those of us who, I'm not a person with lived disorder, but those of us who don't have those experiences with us, that also exists within the recovery community as well. And so those individuals who typically work within the recovery community also have this distinct feeling around who should and who should not be utilizing MOUD. And sometimes those are not underneath the guise of a physician's care. And so the more that we can talk about making sure that we think about treatment as a medical condition and in a medical facility, and frankly, under the guise of those with medical training, the more likely we should be thinking about the use of medication for opioid use disorder. And I'm really hoping that as we move forward into the future, that we really think about the use of evidence-based practice, which is MOUD, in our treatment facilities and allowing that no matter where you are.
And I'm going to second Glenn's call here that reporters can play an awesome role here because a lot of times it's not clear if a treatment facility allows this or uses the gold standard of care. So what I have seen lots of local reporters do is, the county or the state awards opioid settlement funds to some entity. They put out a press release. They send it to you. They want you to write about it. Just make the call to that facility and say, hey, what kinds of treatment do you provide? Do you allow buprenorphine? Do you allow methadone? And if they say yes, cool, like that wraps into your story of like opioid settlement funds were awarded. If they say no, now you kind of have an accountability piece of the state or the county or whomever is giving money to a place that is not using evidence-based practices. So it's a really great and not terribly difficult way to have some accountability in your reporting. So as we get to the last sort of 12 minutes here, I'm going to try to emphasize the questions that are coming in through the Q&A. So if you all in the audience have them, please put them in. I'll try to focus on those. One that I had kind of typed in an answer, but want to put forth to both of you. Morgan asked, are there any problematic ways journalists have covered the opioid epidemic / substance use disorders and possible solutions in the past that we should avoid? And I know this could be this could be its own panel, but if you all want to take sort of a stab at just one quick example or one quick tip on that. Go for it, Chastity.
Oh, sorry, Glenn. I thought you were raising your hand on it. I think there's been lots of examples over the years, and well, daily. It's different with every reporter. But I think not focusing on the stigmatizing words, like we see that so often where it's addict this, addict that, or the images are syringe litter, and it just portrays like the terrible picture that you would expect to see in a movie instead of the humanizing side. Like, hey, we're just people. Like, we may have a substance use disorder, but we're just people. So look at us that way and not report like everybody who uses drugs is a criminal, because they're not. Like, it's across the board people who use drugs, and not everyone who uses drugs has a substance use disorder. And I think there's lots of times the way that it gets written about, it's everyone who uses drugs has SUD and everyone who has experienced an overdose. And that's just not the case. So I think just like really humanizing things would be really helpful, and be really thoughtful in the images that you use, and call out the people who are not, because that makes a big difference.
Go ahead, Glenn.
I agree with everything you just said. One of the other things that I think is important for us to remember is that a lot of times there is lots of really good intentions around our reporting and our telling of stories. But sometimes, even in those really good intended stories, there are ways that we are continuing to help to, unfortunately, re-emphasize some of those stigmas. And so one of the things that I really hope that you think about is even those good intentions that you might have, and finding ways to humanize those stories, or maybe you're just trying to cover someone's individual experience. Helping them understand the use of language is really important. And so sometimes individuals who with lived experience don't realize that they're also helping to perpetuate some of the stigmatizing perspectives based on the language in which they use. So you have to sometimes coach them in that way. And one of the best ways that I've found to help to understand my own perspective is I work with the Shatterproof organization. They have a great guide around specifically the use of stigmatizing language and how it is that we can think about different types of language in order to move our perspective forward. So they have a great guide. It's on their website. And then second of all, I would be remiss as a researcher who studies this, that I work with really great colleagues in communications, and we have demonstrated different ways to make sure that we can actually increase stigma through the stories that we tell, but we can also find ways to decrease it. And so utilizing some of that research and utilizing some of the evidence, my wonderful colleague, Rachel Smith, is a fabulous communication scholar, and she's doing great work to help to find ways to make sure that we're taking the things that we're learning and applying it out in the field.
And the plug I will make for my favorite resource, which is what I typed in response to this question, is reportingonaddiction.org. So this is a group of addiction experts, researchers, as well as journalists who came up with guidelines on how to report on this. They have experts, like a source database that you can go to, and people who agreed to respond quickly to a reporter. They have language guides. They have photo visual guides, to Chastity's point about not using the same stock images. So definitely check that out as a resource as well. All right, I want to share Alan's question here, which is, other than fatal overdose rates, are there good public health measures for journalists to be watching to see if settlement funds are effectively abating a state or community's overdose epidemic? Whichever one of you wants to take that first, go for it.
This is everything that I'm currently working on. So if you want to follow up with me, we are in the process of helping to identify some of those measures and monitoring them over time. And what you need to be thinking about is this. When we look at the span of someone who uses substances, that might start with in the womb, and this might be somebody who has been exposed to opioids through neonatal abstinence syndrome, right? And so finding ways to understand some of those all the way to those who are in the recovery process, and finding ways to find measures that will help you to understand that along the way. So neonatal abstinence syndrome rates is really important for us to be thinking about. Utilizing youth substance use related rates is really important for us to be monitoring over time. Finding ways to make sure that we're thinking about healthcare utilization. So HCUP, healthcare utilization data. They provide emergency room as well as admittance data across multiple locations. There's EMT data, so people who respond to emergencies. There's also naloxone administrations. And then there's also places that are starting to emerge. Vermont is doing a really great job in this. They're helping to connect different data sets so that when things do pop up, they can say, oh, I wonder if this is occurring in other locations across geography, so that we can then help to warn these other communities that there might be an infiltration or an adulteration of illicit supply that might lead to X, Y, or Z. And so there's a whole host of ways that we can start to think about how communities are connected, both geographically, but also, frankly, through some of the data that we know about. But that's me.
Did you want to add anything to that, Chastity?
I wasn't gonna, because that was definitely a great answer. The only thing I would add is I know in Maine, like our syringe service programs, our recovery centers, like we all have to report out our referrals and broken down by all the different types of referrals. And I think following that is really a helpful way to see how effective some of the programs that are getting funding are working. And I don't know about other states, but that's all public to be able to access. So hopefully other states, it's the same way.
Yeah, I used to work in North Carolina, I used to live and work in North Carolina, and there the syringe service programs file an annual report to the health department about, how many doses of naloxone did they give out, and how many people came back and reported using the naloxone to reverse an overdose. So that's another sort of measure that at least was available in North Carolina.
Yeah, I actually was just looking at our data today, and for Maine's data, 25% of overdose reversals are in the community. So that's low because there's so many that aren't being reported, and that is an exceptional number. 1% of reversals are law enforcement. So I think like something like that, that also, I guess this answers the other question about destigmatizing harm reduction. Looking at that kind of data to show how involved the community is, and that people who use drugs, they are the first responders. And looking at that across the board would destigmatize harm reduction in a lot of ways.
Thank you for wrapping. I was worried we wouldn't get to that last question. So thank you for that, wrapping that into your answer. So as we're at the end of our time here, what I'm going to do is very quickly drop in three links into the chat for everyone. The first here is a guide. Full disclosure, I wrote this, but it's using various databases and resources to try to give local reporters tips on how to take a topic like the opioid settlement funds and come up with local story ideas. The other two resources I want to share, one is opioidsettlementtracker.com. This is a really wonderful website that has just a host of information about how much money each state is getting and expecting, how they're spending it, what spending reports they've put out. And then the third one is AppalachiaOpioidRemediation.org, which this is, as the name would suggest, only specific to Appalachia, but it's a group that's doing wonderful tracking of going into county and city meeting minutes. And anytime they mention opioid settlement funds, pulling that out and putting it into a searchable database. So if you live and report in Appalachia and are curious how places are using the money, definitely check out their database. And in our last minute, I will ask each of you if you want to add any resources to that list.
I am going to add one thing that really is completely unrelated, but it goes to something I said earlier, to the question about mobile services. At the beginning of the pandemic, I did a very short 18-minute documentary with the state of Maine called Recover in Maine, Washington County, and it was following me doing the mobile program and connecting with some participants. Definitely has nothing to do with opioid settlement dollars, but if it helps to see how a rural program can look, that's there.
Thank you. I haven't seen that either, so I'm excited.
That's great. I was just going to add, so we are helping to coordinate some of this work across the Commonwealth of Pennsylvania. It's called the Elevate Pennsylvania Initiative that is connecting 3 higher education institutions, the trust, not-for-profit organizations that touch every single county. And then what we're doing is we're developing ways to both help to support counties as they think about utilizing these funds, but also ways to evaluate and measure their impacts over time and then feeding that back to those counties. And so we want to make sure that these data can hopefully help to support this work, not just in Pennsylvania, but across hopefully the country. And so if you're at all interested in this, I will admit the link I'm about to give you is terrible, but we will be creating a new website and launching it here in the next roughly 10 weeks.
Awesome. Thank you both so much for taking the time and sharing your expertise and your experiences on this. I can vouch that folks can reach out to these people as sources. They're wonderful, and they also have a bunch of other colleagues that they will be able to point you towards. People can also feel free to reach out to me if you're looking for tips or ideas or just want another reporter to weigh in on approaching opioid settlement funds or getting your editor to say, yes, I have a lot of experience beating my editors into allowing me to do these stories. So thank you all for joining, and a quick plug for folks who are interested in the substance use space and sort of overlooked issues. The documentary that they're going to show at the next session, Inheritance, does a really great job. I got to watch it when they brought it for the DC Documentary Festival. It does a really great job of kind of getting into the nuances and really the humanizing of this issue. So go check that out if you're interested in this topic. But thank you all for being here.